What do social determinants of health tell us about cardiac arrest? Today on MAJC. Hey everybody, welcome back to the Monday Afternoon Journal Club. Ed Bowder and Dan Schwester here for another MAJC Monday. How are you doing, Danny?
Doing all right.
Today we are going to be looking at data that looks at social determinants of health in cardiac arrest. This paper came out of Case Western Reserve out in Cleveland. Is the other center in Cleveland. That's not the Cleveland Clinic. And we looked at, essentially what this study looked at was social determinants of health, which are everything that's not medical, right? So it's race, financial situations, age, things like that. And they looked at how they affect cardiac arrest. And I suppose we might not be too surprised, Danny, to find out that if you're a member of a minority group, or if you're less financially astute, you don't have as much money, it seems your outcomes are almost destined to be worse than people that have money.
Yeah, that's what this study tends to show. It's a retrospective analysis, and we'll get into the numbers in a few minutes, but it does appear that for certain populations, the more social vulnerability you have a higher risk of dying from out-of-hospital cardiac arrest. There's a ton of factors involved here, but social determinants of health, like you say, take in a lot of factors. And it shouldn't surprise us that these communities do have a higher risk factor and a less of a chance of doing well when they have more vulnerability. I'm really kind of just surprised that it was this significant. And I think for almost all the populations, except for a couple really odd things, the vulnerable populations we think are the ones that are suffering.
And as you can see here on these graphs here, so what they looked at was the social vulnerability index, and they used that as a comparison. The vulnerability index is exactly what it sounds like. So, the more likely you are to be vulnerable just because of your social situation. And so here we see, most of the patients above 65, which is probably not a surprise for cardiac arrest. In this paper, they cite 10.3% as cardiac arrest survivability. So we see that these people who are more elderly, who have more years underneath them, the more socially vulnerable they are, the worse their outcomes are. And that was kind of one of the big things that spoke to me in this paper, because I think it's something that we probably at least think that we know, right? If someone doesn't have access to funding, or access to money, then they don't have access to medical care. If they don't have access to medical care, then they can't get to the hospital. And it's certainly possible that these people live in more rural regions where they just don't have access to pre-hospital medicine. So one of the things that we talk about a lot in these journal clubs is what can we change, right? What can we learn from it? What can grow from it? Or how can we grow from it, I guess? And I think one of the most important things here, this paper doesn't look at clinical data. And again, I want to give credit to Megan Dillon et al. For writing this paper, but it doesn't talk about how to improve cardiac arrest. It doesn't talk about what medications work. It literally just looks at the variable of does the patient have access to funds, and what type of social background does this patient have? So it gets back to this question that we've certainly talked about a lot off the air and on the show, is when we get into, the idea of medical racism, which is certainly a thing that you and I talk about it, but I don't know, as an industry, we talk about it enough. And this data seems to kind of correlate to if the patient lives in a poorer neighborhood, just that variable seems to coincide with reduced outcome.
Yeah, it was really interesting. I thought there was a couple variables that kind of got my attention. Number one, when they looked demographically, it looked at Hispanic people tended to do a little bit better statistically in this study than other ethnicities. Again, we don't know why. This is this data set. We can't really extrapolate, and it's something that probably needs more work. The other thing that was interesting, a big social determinant of health that they didn't include to this, was insurance coverage. And that could be that could have made this even more statistically significant, because if you don't have good health insurance, and, notwithstanding ACA and all the other things that have come in, but if you're not getting good quality preventative care and primary care, you're not getting your high blood pressure meds, you're not getting dietary counseling, you're not getting your diabetes managed. And all of these things kind of snowball, right? It's not that it's not just one thing, but this is definitely showing that there's more factors than at play than we thought maybe before.
And they talk in this paper, and again, this is a retrospective study, so it's just chart review, which is important, right? That there's information we want to get from those. So that, just to be clear, this wasn't blinded, this wasn't placebo controlled. But when we talk about access to private care to a general practitioner, one of the things that they found, that's mentioned in the discussion, is that patients who had an ED visit prior to their admission for the cardiac arrest actually had a higher mortality. And now that I think probably is a function of they reported seeing a doctor, so they might just have better continuum of care. But anecdotally, how often do you go on to scenes and you'll have them be like, oh, well, I just went to the doctor yesterday and they told me that my heart was fine. And, they're throwing ST elevations and all of that. So it's interesting that you have, like, we kind of, I think, as I said, I think intrinsically we sort of know that there are social determinants that affect your care one way or the other. But what I think is interesting is that there was a correlation to having worse outcomes after having seen a private physician within a week before that cardiac arrest. This paper didn't make an effort to evaluate why that was the case. And there's certainly a lot of things that we can discuss from it, but it seems interesting, at least, that, you go to see a doctor, the doctor evaluates you, and then a week later you have your cardiac arrest. So these patients who were doing, the right thing for all intents and purposes, going out to see their doctor, and they're the ones who get sicker. But again, if you're someone who you have to make a choice between buying your medicine or buying dinner for that night or that week, you're almost always going to err on the side of buying things for yourself and not buying your medication. We know that hypertension is, it's always called the silent killer. And we know that hypertension disproportionately affects people of color. So it's interesting, I think, to see this data where I wonder what percentage of patients or potential patients are out there who they're not managing their chronic illness, and not managing their chronic illness is going to directly lead to contact with us.
Sure. And also the interesting point about the people with the ED visit in the week prior having a higher mortality. Think about it. If you're using your emergency department as primary care, which it's not intended to be, but a lot of places that's what you have, things are going to fall through the cracks. And that's by the necessity of emergency care. They can't track the patient for years and months like primary care does. If you don't have good access to primary health care, you're at a higher risk. You are at a higher risk for these factors. And it appears in this study that that's disproportionately tied to how well you're doing in this society. And that's some food for thought.
And something that we mention in every journal club is we always talk about, trying to get hope from it, or, every good paper ends with, more data, more research is required from this. But what I thought was really interesting, and one of the reasons that we wanted to talk about this paper, is toward the end, they mentioned that the database doesn't provide patient-level data. So it's not representative of one patient. And specifically, they mentioned the line is, for the adjusted analysis, there are 1,008 permutations of patient characteristics, although there are more than 200,000 cardiac arrests. So again, you see in 200,000 patients, which is a huge sample size, by the way, you see that there's more than 1,000 different presentations. So this study is not holistic. That's not what we're trying to say. When we talk about things that are potentially practice changing, this isn't a practice changing thing. This is more of increasing the awareness of the culture and society in which you're working, right? Danny, you and I have worked in various settings. We've both worked in cities. We've both worked rural. We've both worked in the suburbs. And it's just an observable fact that the patient populations that you'll see in the city is different than the patient population you're going to see in the suburbs. It just is. And there's a million reasons for that. But this paper, I think, should bring to providers kind of almost the scope of understanding that the ways in which people live can and will be a factor in their care, right? Where if you have someone, as I said, if they just can't afford their medicines, then you have patients who have high blood pressure, diabetes, various chronic illnesses that just aren't being taken care of, which is going to lead them to worse outcomes. So prolonged hypertension, they're going to have sclerotic vessels. If they have diabetes, they might have neuropathy and more sclerotic vessels. They might have, narrowing of their vessels. They might have all of these different things that lead toward heart attack and stroke. And silent killer again, right? We don't know what they actually have. So it may just be that while this data set is interesting, it might be, if you're a provider and now you have access to this data, you might just want to kind of keep that in the back of your mind, right? I'm working in a city today, and I know that if I work in a city and I'm going to a high rise, that this high rise is mostly populated by people who are on Medicaid, who are receiving government benefits or unemployment, or however you want to phrase it. So it might just be that, sort of, if you're going into a cardiac arrest as is, you should be having a conversation with your partner or with your student or whoever you're riding with and say, like, listen, we know this is a cardiac arrest. We want to do A, B, and C. It might just be that this paper can add an additional element to what you're doing in your response, right? We know this patient has these illnesses, they have these problems. Maybe their hypertension was uncontrolled and that led to this cardiac arrest, which, you never want to be that cynical person on scene where it's like, well, it doesn't affect my care one bit. And that may be true, but when you get to the hospital, you're going to want to explain, like, this patient has had a 15-year uncontrolled history of hypertension. So again, it might not be that this is huge or practice changing, but it's interesting, and it's something we should consider when we see these patients.
Yeah, definitely. Again, when I said it's food for thought, I don't think it's going to be anything that's going to jump out and change practice overnight. It is an interesting talking point to start at, to have the discussion about what we really need. And honestly, maybe the key to increasing cardiac arrest survival may be to better increase primary care and the best cardiac arrest is the one we don't see because it never starts that way. That may be what this is pointing to. But again, lots more data needs to be done. A lot of people need to look at this stuff. And I think we're moving into an era of medicine where we're doing a lot more personalized care. We're starting to find out, people's gene profiles and their genome has a lot of effect on how they treat, certain diseases and chronic conditions. And we might be moving towards that in EMS. That day might come. It may not come with me, but that's what the future holds.
I love the idea of doing genetic analysis on a patient at the bedside.
Tricorders.
Exactly, like those old the old lactate meters, but you're just drawing, like, oh, they have a mutation of gene number 9. But no, and I think that's mostly right. Where again, this doesn't actually change things, but might change your opinion a little bit. And one of the most important things to remember when you're looking at patient populations is that up until very recently, medicine taught everything based off of a 70-kilogram white man. Almost none of us, by the way, are 70 kilograms, but that was the considered the ideal, right? That ideal body weight thing. So medicine as an industry is starting to move toward more personalized care, like you said, but also we're starting to acknowledge that different patients, different population, something as simple as male versus female might actually experience illness and disease differently. There's anecdote of women's feminine products, hygiene products that were tested with water up until about 2 years ago. So, there's going to be, I think there's going to be more of this data that rolls out that says things like, listen, not all patients are created equal. There is a difference between each patient that you see. And it's something that we have to kind of keep in mind. It's something that's going to be important for patient care moving forward. But let us know what you guys think. This paper is linked down there in the show notes. Be sure to subscribe to the Overrun here on YouTube. Check out the podcast on Spotify, YouTube, and wherever you get your podcasts, including Apple Podcasts. And for the Overrun, Ed Bowder and Dan Schwester from the Journal Club. Oh, and check us out on EMS One as well. We do a bunch of news stories on there. So click subscribe, do all the things. Let us know what you think, and we will talk to you next Monday.